Hello, and welcome back to another stream of Advanced Pathophysiology. Today we're looking into Chapter 23, Obesity and Disorders of Nutrition. This looks like it's a relatively quick chapter, so we'll jump right into it. Adipose tissue. Adipose tissue provides insulation and mechanical support and is the body's major energy reserve to fuel and other tissues. As an endocrine organ, white adipose tissue, or WAT, contributes to the regulation of energy homeostasis by secretion of adipokines that function like hormones with autocrine, paracrine, and endocrine action necessary for metabolic function and immune responses. Adipocytes are fat-storing cells and store excess energy in form of triglycerides, synthesize triglycerides from glucose, and mobilize energy in the form of free fatty acids and glycerol. Adipokines include all of the biologically active substances synthesized by WAT, which function in the control of food intake and energy expenditure. Lipid storage, insulin sensitivity, immune and inflammatory response, coagulation, fibrinolysis and angiogenesis, fertility, vascular homeostasis, blood pressure regulation, and bone metabolism. Excess fat causes dehydration of the adipokines, contribute to the comorbidities of obesity, and the most common adipokines are summarized here in this box. So we'll jump right in. And we'll actually look at that. So, increased in obesity, you have your acylation stimulating protein, also known as complement 3A. Then you have your angiopoietin related protein 2, your angiotensin type 1 and type 1 receptor, renin and angiotensin converting enzymes, your leptin, your resistin, your retinol-binding proteins, and your serum amyloid, aspirin, visfatin. And then there's things that decreased or that you'll see with decreased in obesity. Your adiponectin, your apelin, and your regulators, which for some reason don't get their own categories. So adipocyte apolipoprotein E, your hormone sensitive lipase, lipoprotein lipase, and lipotransin, and then your pro inflammatory cytokines that are increased in obesity, your interleukin 6, monocyte chemoattractant protein 1, and macrophage products. So, your adipose tissue is classified according to the color of what? Brown adipose tissue, BAT, and beige adipose tissue, a different kind of BAT. These tissue types are found in different locations, have different gene expression patterns, different rates of lipogenesis and lipolysis, and different origins. The origins of different adipose tissue depots are complex and unclear, and likely associated with the heterogeneous function of their different locations. Most adipose tissue in the body is what? What is located in visceral and subcutaneous stores. What also is found in muscle groups, providing mechanical protection and sliding of muscle bundles and bone marrow. What has a stromal structure that contains macrophages, mast cells, neutrophils, fibroblasts, endothelial cells, blood vessels, nerves, and precursor adipocytes. White adipocyte contain a single triglyceride fat droplet or vacuole. Visceral adipocytes store fat as triglycerides, primarily in the form of very low-density lipoprotein, derived from hepatic and dietary sources. A low nutritional state, stimulation of the beta-adrenergic sympathetic nervous system, and release of catecholamines, your epinephrine and norepinephrine, activate hormone-sensitive lipase, triggering lipolysis and what? To release FFAs and glycerol in the circulation. Pancreatic insulin can inhibit lipolysis by activation of insulin receptors in adipocytes. With obesity, adipocytes are resistant to insulin lipolysis. When energy balance is positive, excess fat is stored in mature white adipocytes, which undergo hypertrophy and adipogenesis, your hyperplasia, formation of new fat cells from pre-adipocytes. Chronic positive energy balance can overwhelm adipogenesis, and fat storage then depends only on the hypertrophy. Your visceral VOD is more likely to store fat by adipose tissue hypertrophy, produce more adiponectin, less leptin, and more inflammatory cytokines, and result in central or visceral obesity. Your visceral hypertrophy is associated with release of numerous adipokines, greater macrophage infiltration, increased vascularity, insulin resistance, a chronic pro-inflammatory state, and altered lipid metabolism, all characteristics of the metabolic syndrome associated with obesity. Insulin resistance result in type 2 diabetes mellitus, and excess lipolysis leads to increased release of FFAs into the circulation. With chronic increased energy intake, the increase in adipocyte size and visceral VOD exceed the supporting vascular supply, resulting in hypoxia and inflamed and fibrotic adipose tissue. Excess FFAs are distributed to non-adipose cells, and when their utilization capacity is exceeded, cellular dysfunction or death can occur. Your lipotoxicity, for instance. The increase in FFAs and inflammation contribute to the cardiovascular disease, non-alcoholic steatohepatitis, and other disorders associated with obesity, including carcinogenesis. Your subcutaneous fat is more likely to store fat by adipogenesis, your hyperplasia, with smaller adipocytes and greater fat storage capacity. Subcutaneous fat has higher leptin production, lower adiponectin production, lower production of inflammatory cytokines, lower association with insulin resistance, and is healthier expansion of fat tissue. Thus, the complications of obesity are related to where fat is stored, not just the accumulation of fat stores. Estrogen and estrogen receptors have a role in fat metabolism and enhance the deposition of fat in the subcutaneous tissue and inhibit its visceral tissue. Estradiol increases alpha adrenergic receptors in subcutaneous adipose tissue, but not in visceral adipose tissue. The ratio of alpha adrenergic receptors to beta adrenergic receptors in the subcutaneous adipose tissue in premenopausal women is increased and accounts for a lower lipolytic response to epinephrine and norepinephrine as compared to adipocytes for men. This ratio is reversed in visceral adipose tissue in women. This may explain the higher incidence of peripheral obesity among premenopausal women and the increase in central obesity with menopause and in men. Your brown adipocytes have multiple lipid droplets or vacuoles and are rich in mitochondria that contain iron, giving them that brown color. Exposure to cold, activation of the sympathetic nervous system, and catecholamines, and activation of your triiodothyronine, your T3, stimulate BAT to rapidly generate heat through the activation of uncoupling protein 1, your UCP1, non-shivering thermogenesis. That UCP1, or uncoupling protein 1, promotes mitochondrial respiration and dissipates chemical energy as heat from increased glucose and free fatty acid oxidation. This occurs at a rate of 50-fold greater than that of WAT and protects against obesity and metabolic syndrome. Estrogen-related receptors also participate in the induction of UCP1 in response to cold adrenergic stimulation in BAT. Neonates generate body heat from fat primarily located in the interscapular and perirenal regions. It was traditionally thought that this brown adipose tissue did not persist into adult life. However, using positron emission tomography or PET scanning methods, it is now known that adults also have UCP1 positive fat. It is most common in lean individuals, usually located in the neck, supraclavicular axillary, paravertebral, and perirenal regions. Your muscle myokines, your irisin and fibroblast growth factor 21 also promote that thermogenesis and protects against obesity. Leptin and adiponectin are minimally produced by bat, so there is little effect on diet and satiety. There also is an inverse relationship between the amount of fat, body mass index, and age. Inter-individual differences in fat-mediated thermogenesis may explain some of the variability in obesity, susceptibility, and increased prevalence of obesity with aging. Variation in fat and bright adipocytes, BATs, also may participate in natural regulation of weight reduction. Located within the VAT, particularly in subcutaneous fat depots, are beige or BAT, from brown and white, a subpopulation of white adipocytes that also contain multiple mitochondria and UCP1, but not in amounts associated with BAT. Beige adipocytes are thermogenic and emerge within VAT with chronic exposure to cold, with exercise, and with exposure to synthetic ligand of peroxisome proliferatory activated receptors, gamma or p-peri-gamma, such as the thiazolidinodione (TZD). This is known as beiging of VAT. They disappear with elevated ambient temperatures. Chronic exposure to cold also stimulates VAT transdifferentiation to BAT, which is thermogenic. With warm adaptation, BAT reverts to VAT. Exercise also promotes browning of white adipose tissue, and several myokines are involved in the crosstalk between adipose and muscle tissue. Leptin and insulin together promote BAT, increasing energy expenditure and weight loss. BAT is diminished in obesity since beiging or browning of adipose tissue protects against obesity and metabolic syndrome. Efforts are in progress to discover if there is a way to stimulate synthesis and activity of BAT as an approach to preventing or treating obesity and diabetes. Your bone marrow adipose tissue, MAT, is found in all bones, but in greater number in long bones. MAT released adipokines with autocrine, paracrine, and endocrine effects. MAT has paracrine effects associated with both osteoblast function and endocrine action that affect distant organs, including the cardiovascular system. In general, excessive MAT is associated with osteoporosis, obesity, and alterations in adipokines, activation of macrophages, and release of inflammatory mediators are associated with rheumatoid arthritis. Loss of visceral and subcutaneous adipose tissue, as occurs in anorexia nervosa, result in the accumulation of MAT and osteoporosis. The mechanism is associated with a decrease in myokine, delta homolog 1 protein or DLK1, which inhibits adipogenesis, and hypoleptinemia, resulting in increased adipocyte and osteoblast differentiation. So let's talk about obesity. Obesity is an increase in body adipose tissue and an endocrine and metabolic disorder that has become epidemic worldwide. Obesity develops when caloric intake exceeds caloric expenditure in genetically susceptible individuals. The incidence among US adults was 36.5% between 2011 and 2014, and 17% among children and adolescents between the ages of 2 and 19. Children tend to become obese adults. There are ethnic differences in rates of obesity. Your non-Hispanic blacks have the highest age-adjusted rate at about 48%, followed by Hispanics at 42.5%, your non-Hispanic whites at 34.5%, and non-Hispanic Asians at about 11.7%. It is projected that 42% of the people in the United States will be obese in 2030. Obesity is defined as a body mass index or BMI that exceeds 30 kilogram divided by your metric square in adults and a BMI greater than or equal to the age and sex-specific 95th percentile of the 2000 Center for Disease Control and Prevention of Growth charts in children. Obesity is the fifth leading cause of death in the US and accounts for high healthcare costs worldwide. Three leading causes of death in the United States are associated with obesity: cardiovascular disease, type 2 diabetes, and cancer, usually along the liver, prostate, ovarian, gallbladder, kidney, colorectal, esophageal, postmenopausal breast, pancreatic, endometrial, and stomach. Obesity is also a risk factor for hypertension, stroke, hyperlipidemia, gallstones, your non-alcoholic steatohepatitis, apologies, gastroesophageal reflux, your hiatal hernias, osteoarthritis, infectious disease, asthma, obstructive sleep apnea, and chronic kidney disease. However, some studies have shown that mild obesity in older individuals is associated with lower mortality. But the mechanisms are not entirely clear. The cause and consequence of obesity are multiple and complex, and there is rapid advancing research regarding causal mechanisms, complications, and treatment. Genotype and gene-environment interactions are important predisposing factors. Your single gene defects are rare, and obesity is usually polygenic and associated with other phenotypes, such as endocrine disorders and intellectual disability. Your single gene defects include the melanocortin 4 receptor gene, leptin gene, and leptin receptor gene. All single gene defects are directly or indirectly related to leptin and melanocortin pathways. Metabolic abnormalities contribute to obesity, including your Cushing syndrome, Cushing disease, polycystic ovary syndrome, growth hormone deficiencies, your hypothyroidism and hypothalamic injury. Contributing environmental factors include your socioeconomic status, food intake, and physical inactivity. Obesity also is associated with adverse social and physiologic consequences, including your depression and your mood disorders. So, what kind of pathophysiology would we look at? The pathophysiology of obesity is complex and involves the interaction of peripheral and central pathways, numerous adipokines, hormones, and neurotransmitters. The adipocytes is the cellular basis of obesity, and the most of the adipocytes are white, so you're fat. In the periphery, white adipocytes increase in size and number, store triglyceride, and secrete adipokines. Adipokines and other hormones participate in regulation of food intake, energy metabolism, and other functions, as previously described. Your adipokines circulate in the blood at concentrations that increase or decrease in relation to body fat mass, and promote signal to the hypothalamus, brainstem, autonomic nervous system, and other centers to regulate hunger, satiety, and energy balance. Your visceral fat accumulates, causes dysfunction in the regulation and interaction of the signaling system, and contributes to the complications and consequences of obesity. The following section summarizes the mechanism controlling food intake and energy balance. So I'll leave this up for just a moment. You can take a look at it, and then we'll keep going. So, food intake and energy balance. Centrally, the arcuate nucleus, or ARC, in the hypothalamus regulates food intake and energy metabolism by balancing the opposing effects of two sets of neurons. One set of neuron produces agouti-related protein, or AGRP, and a neuropeptide Y, NPY, collectively known as the AGRP-NPY neurons. These neurons promote appetite, stimulate eating, and decrease metabolism, anabolic. They are known as your orexigenic neurons and are stimulated by molecules called orexins. Another set of neurons synthesize pro-opiomelanocortin producing peptide and cocaine and amphetamine related transcript, your CART, collectively known as your POMC CART neurons. These neurons suppress appetite, inhibit eating, and increase metabolism. They are known as anorexic neurons and are stimulated by the molecules called anorexins. The orexin and anorexin signaling pathways are transmitted through the autonomic nervous system and endocrine system to regulate appetite, food intake, energy metabolism, and body temperature. The hypothalamus also communicates with higher brain centers related to reward, pleasure, memory, and addictive behavior. These centers can override hypothalamic control of food intake and satiety, increasing consumption of highly palatable foods, resulting in increased fat stores. So, examples of hormones and neuropeptides that influence your eating behavior. Again, those orexins and your anorexins. I'll leave that list up for just a moment. You can take a look, and we'll keep going. Your adipokines and hormones released from the gastrointestinal tract and pancreas interact with brain centers, your adipose tissue gut-brain axis, and play a significant role in the pathophysiology of obesity. The major adipokines and hormones are reviewed next. Leptin is a product of the obesity gene, or Ob gene, and expressed primarily by adipocytes. High leptin levels in the normally fed state act on the hypothalamus to inhibit the orexigenic AGRP-NPY neurons and stimulate anorexigenic, your POMC and /CART neurons, to suppress appetite and increase energy expenditure. At low leptin levels, leptin stimulates food intake and reduces energy expenditure. This balance regulates body weight and energy expenditure within a fairly narrow range. Leptin levels increase as the number of adipocytes increases. However, high leptin levels are ineffective at decreasing appetite and energy expenditure, a condition known as central leptin resistance. Leptin resistance fails to inhibit orexigenic hypothalamic satiety signaling and promotes overeating and excessive weight gain. Leptin also regulates hepatic gluconeogenesis, insulin sensitivity, and glucose and lipid metabolism in the liver, muscles, and adipose tissue. Your peripheral leptin resistance results in hyperglycemia, hyperinsulinemia, and hyperlipidemia, and stimulates macrophages and endothelial cells to produce pro-inflammatory mediators. The cause of leptin resistance is unknown. It may be related to a defect in the leptin transport, an inability of leptin to cross the blood-brain barrier, an alteration in the permissive effect of leptin, or a defect or suppression of leptin receptor. The low-grade inflammation accompanying obesity also is thought to contribute to leptin resistance. Chronic hyperleptinemia also stimulates the sympathetic nervous system. Oxidative stress, chronic low-grade inflammation, and ventricular hypertrophy, and contributes to the pathogenesis of hypertension, atherosclerosis, cardiovascular disease, and cancer associated with obesity. Your decreased beta cell function and insulin resistance are associated with obesity. The mechanisms aren't clear, but there is an association between hyperlipidemia and fat storage, macrophages and inflammation, and alterations in adipokines. Leptin resistance and decreased adiponectin contribute to insulin resistance. Insulin resistance results in hyperinsulinemia, hyperglycemia, and a predisposition to type 2 diabetes. Your retinol-binding protein 4 binds vitamin A, is an adipocytokine produced both in the liver and by adipocytes. It is increased in visceral adiposity and contributes to the inflammation and insulin resistance in the liver and muscle, and is associated with hepatic steatosis and cardiovascular disease. Your adiponectin is produced primarily by the visceral adipose tissue, but is also produced by cardiomyocytes and skeletal muscle. It has insulin sensitizing and anti-inflammatory properties, and plasma levels decrease with visceral obesity, contributing to insulin resistance and type 2 diabetes. Decreased adiponectin levels are associated with increased hepatic gluconeogenesis, decreased skeletal muscle glucose uptake, and increased levels of inflammatory mediators such as interleukin 6 and tumor necrosing factor alpha. Adiponectin may serve as an anti-inflammatory and anti-atherogenic plasma protein. It has an important role in vascular remodeling and is cardioprotective. Decreased levels of adiponectin are associated with increased risk for coronary artery disease, resulting from hyperlipidemia, hypertension, and factors that promote thrombosis and inflammation. Your endocannabinoids, your an, ana, ooh, butchering that one, anandamide, are arachidonic acid derivatives expressed in both the brain and the peripheral nerve tissue and have effects on endocannabinoid receptors and or exogenic pathways. They increase appetite, enhance nutrient absorption, stimulate lipogenesis, and increase white adipose tissue accumulation by acting on both central and peripheral sites. They also inhibit energy expenditure and thermogenesis. An increase in endocannabinoids is proposed to be associated with obesity. Your angiotensinogen is produced in the liver and adipocytes and is increased in obesity. Your angiotensinogen is the precursor to angiotensin 1, which is then converted to angiotensin 2. The effects of angiotensin 2 include vasoconstriction, renal retention of sodium and water, and the release of aldosterone. Increases or increased angiotensin 2 from adipose tissue also promotes inflammation, lipogenesis, oxidative stress, and insulin resistance, all of which contribute to the hypertension, atherosclerosis, diabetes, and cancer associated with obesity. The paracrine effects of the renin-angiotensin system in the brain also may participate in the control of energy balance and may be involved in the pathogenesis of obesity and obesity-related hypertension. Gastrointestinal hormones also play a role in the complex pathophysiology of obesity. The most significant are going to be reviewed here. Your ghrelin, your glucagon-like peptide 1, peptide YY, amylin, pancreatic polypeptide, and your cholecystokinin. So, talking about ghrelin. Ghrelin is produced by the stomach gastric mucosa in response to hunger and stimulates food intake through activation of ghrelin receptors located on neuropeptide Y, dash agouti-related peptide neurons in the hypothalamus. Ghrelin induces metabolic changes leading to an increase in body weight and body fat mass. Ghrelin also stimulates release of growth hormone from anterior pituitary cells, release of gastric acid, gastrointestinal motility, and pancreatic secretion of insulin. An elevation in levels of free fatty acid and growth hormone after eating decreases release of ghrelin. It also has satiety, vasodilatory, cardioprotective, and anti-proliferative effects. In lean individuals, ghrelin levels increase with hunger and fall during the postprandial interval. In people with diet-induced obesity, circulating ghrelin levels tend to be lower, with blunted meal-related fluctuations. In obesity-induced central ghrelin resistance has been observed in neural circuits. However, the causative mechanism related to ghrelin with obesity have yet to be clearly defined. Signals from leptin and ghrelin are complementary, yet antagonistic, signals reflecting from acute and chronic changes in energy balance, the effects of which are mediated by hypothalamic neuropeptides such as MPY and AGRP. In obesity, plasma ghrelin level does not decrease after eating. Endocrine and vagal afferent pathways also are involved in the action of ghrelin and leptin, adding to the complexity of mechanisms that can affect obesity. Ghrelin is thought to have an anti-lipolytic effect and stimulates lipogenesis in visceral fat. However, with obesity, there is thought to be ghrelin resistance in the hypothalamus. Thus, although ghrelin is increased with obesity, its role in contributing to obesity is yet to be clearly defined. Your glucagon-like peptide 1 is an incretin secreted from intestinal endocrine cells when nutrients enter the small intestine. Glucagon-like peptide 1, or GLP-1, stimulates pancreatic glucose-dependent insulin secretion, delays gastric emptying, suppresses appetite, and increases energy expenditure. GLP-1 levels may be decreased in obese individuals, and GLP-1 receptor analog has been approved to treat both obesity and type 2 diabetes. Your peptide YY or PYY is released from intestinal endocrine cells in response to nutrients entering the intestine and inhibit gastric motility and decrease appetite. The level PYY decreases with increase in adiposity, and decreases PYY level is associated with obesity. Cholecystokinin, CCK, is secreted by proximal small intestinal cells following food intake. Its actions include the gallbladder contraction, release of pancreatic enzymes and insulin, satiation, and reduced food intake. CCK secretion is reduced in obesity. Obesity produces a state of chronic, low-grade inflammation in what? Macrophages, lymphocytes, neutrophils, and mast cells infiltrate enlarged adipocytes and release inflammatory cytokines, the tumor necrosing factor alpha and interleukin 6. Macrophages change their phenotype from anti-inflammatory expression of cytokines, your M2 macrophages, to expression of pro-inflammatory cytokines, your M1 macrophages. The mechanism of macrophage infiltration are thought to be related to adipocyte senescence, necrosis, and death. The inflammatory state is supported by increased levels of leptin and resistant and decreased levels of adiponectin and escalation of eicosanoid-generating prostaglandins and leukotriene B4. The inflammatory state and accelerated lipolysis contribute to the development of insulin resistance and metabolic syndrome, and to the complications of obesity, particularly type 2 diabetes, cardiovascular disease, and cancers. Changes in the intestinal microbiome also are associated with obesity, although the mechanism is not clear. Microbes are found in high concentration in the lower gastrointestinal tract, and bacterial composition is affected by genetics, diet, use of antibiotics and other medications, and energy balance. These bacteria have a considerable variability among individuals and participate in complex carbohydrate breakdown and nutrient absorption, inflammatory responses, gut permeability, and bile acid metabolism. Your gut microbial fermentation of dietary fiber produces short-chain fatty acids, your acetate, butyrate, and propionate, which all function as energy sources and signaling molecules that affect host energy metabolism and inflammation. Your gut microbiota, transplanted from obese mice into germ-free mice or from obese human twin, have shown that the gut microbiota may have a causal role in the development of obesity and insulin resistance. More studies are still needed to determine how changes in the microbiota contribute to body weight regulation, metabolism, low-grade inflammation, and increased adiposity, and how manipulation of the gut microbiota can assist in preventing and treating obesity in the future. So, what are our clinical manifestations when we are talking about obesity? Well, obesity usually presents with two different forms of phenotypes of adipose tissue, distributing visceral and peripheral. Visceral obesity occurs when the distribution of body fat is localized around the abdomen and upper body, resulting in an apple shape. Your visceral obesity is associated with accelerated lipolysis and has an increased risk for chronic systemic inflammation, metabolic syndrome, obstructive sleep apnea syndrome, type 2 diabetes mellitus, cardiovascular complications, osteoarthritis, and cancer. Your visceral venous blood drains into the portal vein, contributing to higher liver synthesis of plasma lipids. Lipids also are located in the intracellular liposomes. In the liver, liposomes can increase in size. Your steatosis, increased fat in the liver, increases the risk for non-alcoholic fatty liver disease, steatohepatitis, and cirrhosis. Your peripheral obesity occurs when the distribution of body fat is extraperitoneal and distributed around the thighs and buttocks and throughout the muscles, resulting in a pear shape. It is more common in premenopausal women. Peripheral and subcutaneous fat is less metabolically active and lipolytic and releases fewer adipose cytokines than visceral fat. Risk factors are still present for the complications of obesity, but they are less severe than those of visceral obesity. Your non-weight obesity, NWO, describes a phenotype of individuals with a normal body weight and BMI, with percent of body fat greater than 30%. These individuals are at risk for metabolic dysregulation, increase in inflammatory cytokines, insulin resistance, increased risk for cardiovascular disease and other complications of obesity, and a higher mortality. Your NWO is estimated to occur in 2% to 28% of women and 3% of men. Another phenotype associated with obesity is metabolically healthy obesity. So, what is our evaluation and treatment for your obesity? All children and adults should be screened for obesity. There are several methods for estimating or measuring the amount of adipose tissue: anthropometric measures including the weight, height, and circumference of various body diameters, skin fold thickness, ultrasound to measure peripheral body fat, and bioelectric impedance and underwater hydrostatic weighing to calculate total body fat. The only method for directly measuring total body fat is via a DEXA scan. The clinical practice, anthropometric and body diameter measures are most commonly used to calculate the body mass index because they are the easiest to measure and most cost-effective. Body mass indices have been established based on height, weight, age, gender, and ethnicity. Overweight is defined as a BMI greater than 25, and obesity is a BMI greater than 30. BMI charts are available for children ages 2 to 20. These can be used for comparison during adulthood because obese children generally become obese adults. However, your BMI does not measure the amount of distribution of body fat. Your waist circumference, more than 40 inches for men and more than 35 inches for women, adds information to assist with disease risk assessment in the general practice. Obesity risk assessment is available from the American Association of Clinical Endocrinologists and the American College of Endocrinology. No specific diagnostic criteria for obesity have been established. Obesity is a chronic disease for which various treatments approaches have been used, including the correction of metabolic abnormalities and implementation of individually tailored lifestyle interventions, such as weight reduction diets and exercise programs. Additionally, treatments include psychotherapy, behavioral modification, self motivation, and support systems. Several drugs have been approved for the pharmacologic management of obesity. Currently, bariatric surgery procedures offer the most significant reduction in weight, reduction in comorbidities, and decrease in insulin resistance for treatment of obesity. Efforts are continuing to identify the molecular and neuroendocrine causes of obesity. This will lead to more specific and personalized prevention and treatment strategies. So that jumps us now to the opposite end, your anorexia nervosa, bulimia nervosa, and binge eating disorders. Anorexia nervosa, bulimia nervosa, and binge eating disorders are psychiatric disorders related to the distorted body image with a desire for thinness and a fear of fatness that results in extreme restrictions in eating habits. These psychiatric disorders are included in the Diagnostic and Statistical Manual of Mental Disorders. Classify, Classification of eating disorders by the American Psychiatric Association. They occur in as many as 1% of young women and adolescent girls in the US and rarely occur in black women. Only 5 to 10% of cases are in men. However, eating disorders also may occur in children and women ages 45 to 50. Your risk factors include genetic, epigenetic, familial, biologic, psychologic, and social factors. So, complications of chronic and severe eating disorders are related to the malnutrition and weight changes, involved all organ systems, and can be life threatening. Most complications are reversible with treatment. However, refeeding syndrome can increase morbidity. The death rate is highest among women with anorexia nervosa, particularly those with a psychiatric comorbidity. So, again, we have complications: GI, cardiac, pulmonary, hematologic, musculoskeletal, endocrine, neurologic, dermatologic, and then bulimia, your self induced vomiting, your laxative abuse. Talking about refeeding syndrome, starvation. Starvation, or malnutrition, is a lack of nourishment from inadequate amounts of calories, proteins, vitamins, or minerals, and is caused by improper diet, alterations in digestion or absorption, your chronic disease, or a combination of these factors. Starvation is a reduction in energy intake leading to weight loss. Short-term starvation and long-term starvation have different effects. Your therapeutic short-term starvation is part of many weight reduction programs because it causes an initial rapid weight loss that reinforces the individual's motivation to diet. Therapeutic long-term starvation is used in medically controlled environments to facilitate rapid weight loss in morbidly obese individuals. Pathologic long-term starvation can be caused by poverty, chronic disease, or cardiovascular, pulmonary, hepatic, and digestive systems. Your malabsorption syndromes, HIV infection, and cancer. Your short-term starvation and extended fasting consists of several days of total dietary abstinence or deprivation. The body responds with mechanisms to protect protein mass. For 4 to 6 hours after the last meal, the body is in a well-fed state, and its energy requirements are supplied by glucose from recently ingested carbohydrates. Once all that available energy has been absorbed from the intestine, Glycogen in the liver is converted to glucose through glucogenesis. The splitting of glucogen into glucose, this process peaks within 4 to 8 hours, and gluconeogenesis begins. Your gluconeogenesis is the formation of glucose from non-carbohydrate molecules, your lactate, your pyruvate, amino acids, and your glycerol portion of fats from lipolysis. Like glycogenolysis, gluconeogenesis takes place within the liver. Both of these processes deplete stored nutrients and thus cannot meet the body's energy needs indefinitely. Proteins continue to be catabolized to a minimal degree, providing carbon for the synthesis of glucose. Your long-term starvation begins after several days of dietary abstinence and eventually causes death. Absolute deprivation of food causes marasmus or protein energy malnutrition. Protein deprivation in the presence of carbohydrate intake is called kwashiorkor. Your marasmic kwashiorkor is a combination of chronic energy deficiency and chronic or acute protein deficiency and inadequate micronutrients. These conditions are all described in chapter 43. Anorexia nervosa is a psychological cause of long-term starvation. Cachexia is physical wasting with loss of weight and muscle atrophy, fatigue, and weakness. Your inflammatory mediators, your tumor necrosing factor alpha, interferon gamma, interleukin 1, and interleukin 6, and an increased catabolic response are associated with the cachexia and advanced cancer. Cancer, AIDS, tuberculosis, and other major chronic progressive diseases contribute to cachexia. Anorexia and cachexia often occur together. Cachexia is not the same as food deprivation starvation. A healthy person's body can adjust to starvation by slowing the metabolic rate. However, in cachexia, the body does not make the adjustment. The major characteristic of long-term starvation is a decreased dependence of gluconeogenesis and an increased use of ketone bodies as a cellular energy source. During long-term starvation, depressed insulin levels and increased levels of glucagon, cortisone, epinephrine, and growth hormones promote lipolysis in adipose tissues. Lipolysis liberates fatty acids, which supply energy to cardiac and skeletal muscle cells, and ketone bodies, which sustain brain tissue. Fatty acid or ketone body oxidation meets most of the energy needs of the cells. Once the supply of adipose tissue is depleted, proteolysis begins. The breakdown of muscle and visceral protein is the last process of the body, engages to supply energy for life. Death results from severe alterations in electrolyte balance and loss of renal, pulmonary, and cardiac function. Your adequate ingestion of appropriate nutrients is the obvious treatment for starvation. In medically induced starvation, the body is maintained in a ketotic state until the desired amount of adipose tissue has been lysed. Starvation imposed by chronic disease, long-term illness, malabsorption syndromes, and chronic eating disorders is treated with enteral and parenteral nutrition. Perioperative or critical care management of nutrition is necessary to prevent unnecessary starvation. Care must be taken to prevent refeeding syndrome during the treatment of long-term starvation. Your anorexia of aging. Anorexia of aging is defined as a decrease in appetite of food intake in older adults and can occur in illness-free individuals and in the presence of an adequate food supply. The resulting undernutrition leads to adverse outcomes and may affect up to 20 to 30% of elders. The anorexia of aging result from multiple age-related changes, including reduced energy needs, waning hunger, diminished senses of smell and taste, decreased production of saliva, altered gastrointestinal satiety control mechanisms, and the presence of comorbidities. Centrally, aging is associated with decreased orexigenic signals and increased anorexigenic signals, which lead to loss of appetite and diminished food intake. Chronic low-grade inflammation with elevated cytokines also contribute to the delayed gastric emptying and decreased motility of the small intestine. Your risk factors for anorexia of aging include functional impairments and deficiencies, medical and psychiatric conditions, loneliness and grief, medications including polypharmacy, social isolation, and abuse or neglect. The consequences of anorexia of aging include malnutrition, physical frailty, mitochondrial dysfunction, reduced regenerative capacity, increased oxidative stress, and imbalanced hormonal levels. There's no currently used specific treatments for the anorexia of aging, though numerous supportive strategies are used. Death rates have been shown to be higher in those with anorexia of aging and unintentional weight loss. And that concludes our chapter here. It was quick and painless. So we'll see you at the next chapter.